on behalf of my co-investigators, I had the opportunity to present some of the updated clinical response and then newly present the molecular response data from patients that were treated with frontline azacitidine plus venetoclax in the phase 1b clinical trial. This was abstract 241 and it was presented on Saturday. In this abstract, we shared that in our cohort of patients who had been treated with combination therapy, we had previously demonstrated and presented the safety. It was most recently updated at EHA by Dr. Andrew Way. And we had presented also the recommended phase 2 dose of azacitidine given at standard doses of 75 mg per meter squared days 1 through 7, plus venetoclax given 400 milligrams days 1 through 14 on a 28-day cycle. And here in this abstract, what we did was we presented the updated clinical responses among patients that did receive the combination therapy. What we confirmed in this study and demonstrated was that not only was the treatment indeed still shown to be safe, there were expected cytopenias, but with adequate lab monitoring and antibiotic prophylaxis, 30-day mortality was 1%. The rates of serious infection were low. Pneumonia was 6%, highlighting the fact that with good vigilance and monitoring as we were recommended per protocol, we were able to carry patients safely through. And that's really important. In high-risk MDS, we're sorely lacking on therapies beyond standard hypomethylating agents. And many of the combination studies haven't been able to cross the finish line due to efficacy. So once you demonstrate safety, what we're all really looking for is clinical response. And then after clinical response, we're looking for survival, which is the gold standard. So in this abstract, we demonstrated that 84% of patients who received combination therapy, and especially those that received it at the recommended phase 2 dose, had an objective response rate of 84%. And that's really quite phenomenal, primarily because our expectations from pooled studies, looking at azacitidine alone, which is a standard of care for high-risk MDS, the pooled response rate is, about 17, 19% for complete remission. And when we took a look at the responses for our patients, including those with a full or true complete remission or CR, and including those with marrow complete remissions, meaning they had, less than 5% blasts, and including those that had a marrow CR plus hematologic improvement, which is a clinically meaningful outcome, we found that the overall response rate was 84%. And this really did include about 35% of patients with a true CR, 49% of patients with a marrow CR, and overall 24% with marrow CR plus hematologic improvement. The median time to response was about 1 month, and the responses were durable for over a year. This is really remarkable. Now, azacitidine is an active drug for sure. That's why it's the standard of care. But in general, our expectations for responses are that it can take 2 to even 4 cycles for an initial response to happen. So we were really happy to see that. Now, complete remissions are of course, incredibly important. That's an initial sign of activity. But what we really care about is overall survival. So with uncensored data, meaning patients that went on to transplant ultimately they weren't censored for transplant. But overall, when we look at the overall survival, the data looks really good. It's not reached for patients that are currently in complete remission, or for those that are marrow CR plus hematologic improvement. When we take a look at the 12-month and 18-month overall survival for those in CR, it's 100%. So what we're seeing is really high overall survival rates, particularly for those that have a deep clinical response. And that was many of the patients, which was really great. When we were being a little bit greedier to understand, what about disease modification? What's happening at the molecular mutational level? Most of our patients with MDS, it's a heterogeneous disease. And many of these patients, in fact, the majority, will carry somatic mutations in the myeloid cells that are clinically meaningful and that have been associated with MDS development. What we were able to find is indeed there were responses or objective complete remissions and marrow complete remissions observed across the entire mutational spectrum, from those that were historically considered to be good or favorable risk mutations or not necessarily prognostic, to those that are traditionally poor prognostic. So as an example, among patients that had TP53 mutations, the objective response rate, meaning those with CR plus marrow CR, was about 85% for those that had mutations in TP53. For those that had mutations in ASXL1, again, a common and generally poor prognostic mutation, the objective response rate was 82%. This clinical trial was not meant or selected just for specific mutational subtypes. It was meant to treat everyone with high-risk MDS. And what we were happy to see was the responses did not necessarily exclude any particular population. We really do look forward to more meaningful data long-term, more patients to understand which are the cohorts that benefit and achieve remissions and responses the longest. Those are things that we still don't have sufficient data on, and which cohorts could be better served by other drugs. In the meantime, we also looked for things because we had availability of paired samples from either blood or bone marrow. We looked for changes in molecular responses, meaning changes in VAF or variant allele frequency. That gives us a sense of what may be happening to the mutational burden. And what we saw was across the board, across the different mutational molecular subsets, that all those different mutation types and mutation risk types achieved a 50 to 98% reduction across different patients. Now, not every patient did achieve that, but almost all the patients that were able to have a really good clinical response were able to also have some sort of VAF reduction. We still don't understand what different VAF reduction level means, but for those that had 59.9%, that was observed across different mutation types. And we even had some patients where their mutations became undetectable using a standard clinical molecular assay, not an MRD assay or minimal residual disease assay, but rather using a standard clinical assay where we look at the level of detection as the lowest level or highest sensitivity. So we were able to observe broad molecular responses, and we were able to demonstrate through swimmer plot how patients that were in remission were able to have long or durable responses. So overall, from this abstract presented at ASH 2021, we were able to reconfirm the safety of the combination, demonstrate again that the objective responses that are clinically meaningful and important to all of us taking care of these patients were again observed with follow-up and with increased patient cohorts or safety expansion cohorts, which is great. We confirmed that those that did achieve a complete remission or marrow complete remission with hematologic improvement had outstanding overall survival, which is really critical. This is not a randomized study, but it was highly encouraging, suggesting there's really great activity with the combination. And then in this abstract in particular, we were able to highlight and demonstrate how the responses were observed across many different mutational subsets, and that was encouraging to us. What was really great, ASH was really different this year. This is, obviously with the pandemic, we were all fortunate to be able to come together. We weren't able to do that in person last year. But our session was well attended. People are really interested to know what is the next trial, what is the next thing we can offer our patients. So everyone was really vocal, asked really phenomenal questions during the Q&A, and it was a really interactive session. The entire session for the trials that were presented had really compelling combinations and results. So we all wanted to learn from each other. What can we do? What can we do next? Where are there holes? What can we do better on? And where are there still questions? So I do think that the data was well received. I think people are definitely looking forward to the ongoing phase 3 clinical trial, which is what we need to confirm safety, confirm responses, and in fact, confirm survival. The primary endpoint of the phase 3 trial with azacitidine plus or minus Venetoclax is a shared co-primary endpoint of overall survival and remission. That really is what's going to tell us whether or not we could change our standard of care. So this was just initial data to demonstrate some promising activity.